roll out in terms of where we want to take things, in terms of our ICU, critical care, direction, and I had a lot of thoughts I laid out, and we felt the need to come and present to you guys today and give you guys an opportunity for those who weren't able to listen to that talk. So this is pretty much what I talked about last week, but just kind of put in front of you guys just to make sure that we're on the same page. Before I really start getting into what I wanted to talk about, I wanted to give you guys kind of an introduction on who I am. So I've worked with a lot of you guys directly, indirectly for a number of years. I've been here for 6 years, going on 7. But I think that, just to give you a little bit of background on how I got here would be a little bit helpful, just so you kind of know where my mindset is. So I'm originally from South Carolina. I've bounced all over. I'm on the boring side of South Carolina, is where I grew up, like in North Augusta, South Carolina, right across the river from Augusta, Georgia. I was on the first thing smoking out of there. I went to college up in New York at Cornell University. I did graduate school at Baylor University. I came back to the more exciting side of South Carolina, in Charleston, to do my medical school training. I did residency and fellowship up in New Jersey at Rutgers, New Jersey Medical School. I've been here for about 6 years. I took the job. I started here in 2019. In 2021, I was blessed with my first leadership role, where I went into the sepsis physician lead for Vermont Healthcare Quality Initiative, and I stayed in that role for about 3 years. Garrett Harp is now transitioned into that role, but I was served in that position for about 3 years. A little bit of overlap where I became the chair of medicine here in 2023, and I am finishing up my term as of a few days from now, where I'm going to be stepping into the president-elect role of the medical staff come January of next year, where I'll be serving on a credentialing committee and whatnot. I also have an educational background and educational interest. Leo Carrasco and myself, we help lead the critical care ultrasound course here locally with Piedmont, and I also teach nationally at the American Academy of Chest Physicians with critical care ultrasound. So I have my hands in a lot of different things, so if you see me going down the hallway all scatterbrained and everything, this is kind of why. But speaking of my reason why, you see on the left, I have my wife and my 2 kids here that keep me pretty busy here. So my 2-year-old Bishop and my 6-year-old Zora, my wife, are here. So they keep me on my toes. So when I accepted this position several months ago, what I wanted to do was kind of really sit down and think about where I want to take things, which direction, where can I be best served in this role. There was a gathering, a holiday gathering of the physicians earlier this month, kind of a holiday mixer, where Steve Porter, our CEO, really talked about the fact that we are having this big transition. When I first started here in 2019, we were a nice community hospital where the ICU was on the west side, and there were times where we had 2, maybe 3 patients. Some of y'all are nodding your heads. 2 or 3 patients in the ICU, and during respiratory season, during the crazy season, there would be like 12, 14 patients, and we were all looking at each other like, oh, what's going on here, right? And so it was super busy. But we have come a long way ever since the COVID pandemic, when we moved over to the east side. If you build it, they will come. So now it looks like our minimal amount of ICU patients are like 12, 13, 14. And we've seen northwards of like 30 patients when it really gets busy. And then I don't even want to speak about the pandemic. But we're having this transition where we're going from a more of a community hospital feeling to more of a regional medical center. That's where we're going. We're bringing in all these different service lines now, and we're really growing exponentially. You for sure heard about the new tower that's being built. So we're just growing to the point where now we're a regional medical center. And with that growth, There has to be a change of mindset in terms of how we're thinking about things, how we're approaching our care, especially our critical care in terms of our patients. And so with that mindset, I wanted to sit down and really come up with some overall framework in terms of how I wanted to make these transitions and these changes. And really it's all about just making sure that we are a high performing critical care ICU that is just our foundations, our communication, safety, and accountability. Making sure that we are in constant communication with each other, inter-department, in the departments, between different floors, making sure that we're keeping patients safe, and in that same breath, making sure that our staff is safe, and making sure that we're just holding each other accountable and everybody's doing their part in their job. Making sure that you guys are feeling supported and that you guys are supported in everything that you do, and that you're empowered to speak up, speak your mind, and make suggestions. I think what you'll find with me is that I'm very easy to approach, hopefully. And when you guys have suggestions, questions, concerns, I definitely want you guys to bring that to me. And with all this said, I want to make sure that we're delivering the best evidence-based care. And to do that, that's going to be depending on staying up with the literature, staying up with all the new research articles that come out and everything. So I want to make sure that we're doing that. So a lot of people in this room, or at least some people in this room, when I first took this position, I had my little listening tour, where I would formally sit down with some folks in this room and out of this room, formally and informally, and really just start to pick your brains, okay? Some of you guys I informally went up to and started asking questions. You didn't realize you were on a hot mic, but you were, where I would just break out my phone and just start listening to you guys, and any suggestions you would make, any concerns, I would write down. And basically, this presentation is a reflection of everything you told me. And like I said, I went to everybody. I went to nursing staff, I went to respiratory staff, my APPs, pharmacy, the chaplain, speech. I went to different service lines and really picked everybody's brains in terms of what they were seeing on the ground, what areas of opportunity we have, and just kind of going through the process on how they care for patients, what they're seeing on their neck of the woods, and seeing what we can do in order to improve our workflows, how we can change things for the better. And like I said, I took that list of suggestions and areas of opportunity that you gave and just plopped it into this presentation and just made suggestions. So what you're seeing here today is things that you said that we need to improve on and how we can improve things. And today is just that framework. This is a work in progress. If you guys have other ideas, other opportunities, feel free to voice those, but these are just kind of common themes that started to arise. So we talked a little bit already about communication. This is actually going to be one of my focal areas because a lot gets missed and a lot slips through the cracks when we don't have proper communication. That's again, in the departments, between departments, handoffs is a big part of that. There was a lot of areas of opportunity expressed by you guys in terms of handoffs, so one of my big focuses is going to be on improving that. I already mentioned that one of my backgrounds was the sepsis physician lead, so obviously this is going to be one of the things that I'm going to be a little bit more passionate about, how we deliver good, proper sepsis care, and making sure that we are meeting our goals and our targets, and making sure that we are efficient and timely in our workflows. Sedation practices and ventilation, liberation. This is a topic of concern that touches on everybody, especially in this room, in one way, shape, or form. If you think about it, this is one of the backbones of treatment that we do in the ICU. If we are meeting our targets, we're getting our patients liberated safely in a timely fashion. When we start to deviate, that's when we start running into issues in terms of self-extubations, in terms of increased vent days, deconditioning, X, Y, and Z. So there was a lot of areas of opportunity there. We have a lot of people coming in that are new, that we have a lot of people that have been here a while that just need refreshers on things, and we talked about making sure we're staying up to date on our evidence-based knowledge. So there's a lot of opportunities for education, making sure that you guys are supported in terms of equipment that you need, in terms of times that you need, anything, just resources, and making sure that we have a opportunity for ongoing training. ED to ICU interface. Yeah, this is a big one. You guys had a lot of comments on this. We will talk about this briefly, but just know that there's going to be more to come on this. I spoke to respiratory therapists, and there's definitely some things that we can work on from that standpoint. And I already mentioned this, but making sure that we're creating a culture of safety, and that is in regards to the patients and staff safety, and making sure that people are held accountable and we're all doing their job. And another big topic of concern is early mobility, nutrition, making sure that we are treating some of our long-term players appropriately and making sure that they have all the ongoing care that they need. So, communication and handoffs. So, some opportunities that you guys identified. One of the recurring themes that was discussed in my conversations with you guys was the nighttime care that patients were getting. There was a lot of, let's call it, opportunities to improve on our care at night when it came to the things getting completed, medications being completed. There was a lack of communication between the day shift and the night shift, and vice versa, and how can we improve on that? There was some specific examples of some issues when a respiratory therapist or a nurse would have some sort of critical lab, and how do we effectively get that to the provider to get acted on. There were times where secure chat was being used for a pH of 7.08, a CO2 of 86, or a hemoglobin of 3, where that probably should have went to the provider directly, hey, banging down the door and all that. And probably some of the reason for the secure chat was because there was door closed to our little workroom at night. So that was a common theme that came up here, and just know that that's being addressed and that's being looked at. We talked a little bit about handoffs already, where you have patients transferring all over the hospital, where you have patients transferring from the main ER to the ER holding area in the back, ER holding area to the ICU, procedural areas, floors, and I look through RLs and I talk to the staff, and there's a lot that gets missed between those transfers to other areas. More on the provider level, where progress notes were difficult to follow as patients were getting transferred out of the ICU, that's going to be addressed. And another thing that I wanted to bring to your attention in terms of opportunities, where we want to give our APPs more thorough feedback. So there's going to be some opportunities for you guys to get involved with that process if there's some issues with our APPs, in terms of hearing that feedback from you guys, so we can pass that on. So in terms of how we can get better with these things, there is already an ICU communication algorithm that exists, that is floating around the ICU somewhere. I think we've gotten away from it, especially with the COVID pandemic, but definitely we want to put that back out there and make sure that it is revised and updated, and make sure that it works efficiently and effectively for you guys. So definitely want to make sure that that is out there. Again, one of my big projects that I'm going to be tackling is handoffs, making sure that that process is standardized, again, between the ER, transfers to the ICU, or going to the OR procedural areas, or patients that are getting transferred out from the ICU to the floors. making sure that we are communicating between our departments in terms of making sure that any concerns between speech, respiratory, nursing makes it to the providers, makes it interdisciplinary, just making sure that we're collaborating and making sure that we're communicating. So opportunities identified for sedation and vent liberation. So what we've noticed is that there are variations in terms of how we go about our SAT/SBT protocols, in terms of the amount of sedation patients are getting, either during the day or during the nighttime. When we're starting our SAT protocols, we're starting to vary away from those, and if you think about it, that starts to lead to other issues that stem from that, right? So if you're starting your SAT a little bit later on because the patient's super sedated, then that's going to delay your spontaneous breathing trial. The patient might get extubated a little bit later in the day, and then if they're extubated later in the day, that leaves a little less time before people start going home for the evening, and then stuff goes down at the nighttime, and there's less staff there, so it's just like a chain event, right? And then if you think about it again, where patients are super sedated and we're falling out of that protocol, that can also lead to self-extubations in terms of inconsistencies in terms of how long we're SBTing patients for. That can also lead to self-extubations as well. So just, there's a lot of opportunities that were identified there. And so to help firm that up, we already have a protocol in place for this. We just want to make sure that it is reviewed and make sure that it is effective for us and make sure that we are making it work for us. Meaning that we start our spontaneous awakening trials typically at 6 a.m. That leads to a spontaneous breathing trial starting at 10 a.m. and we try to get that patient extubated if they're a candidate by 11 a.m. Try to adhere more firmly to a 30-minute spontaneous breathing trial, making sure that everybody's on the same page in terms of RAS goals. Making sure we understand what the difference between a RAS goal of -3 and -2 really is. Making sure that we're talking apples to apples, because sometimes if patients or if staff doesn't understand the scale that we're using, that could lead to variations in terms of how well patients are getting sedated. And to help with this, and we're going to talk about this a little bit later, but we are also looking to create a spontaneous awakening trial, spontaneous breathing trial task force in order to help identify any issues along this pathway. Dr. Panamalan was voluntold to help lead this charge, but we'll be looking into this a little bit more, this process a little bit more. And again, if you think about it, that really involves everybody in this room in terms of that pathway that these patients are taking on in terms of liberating them from the ventilator. ED-ICU interface. So we as in leadership has heard your concerns. I've talked with several of the other leaders in the hospital, and we've heard about the ER holding area and some of the challenges that come with that area. We've heard about patients popping up in rooms unannounced per se and not getting proper handoff. Variability in communication in terms of handoffs and labs that are due, fluids that need to be hung, delayed treatments that happen in that area, and just overall just a concern about patient safety. Just know that, again, the handoff process is being looked at. We are also talking with our lab folks in terms of identifying any potential changes we can make there to make the lab draws a little bit more efficient, and making sure that we are involving our stat team in terms of our treatment of these patients, especially our more critically ill patients. But what I can also tell you is that there are meetings, there are audits happening right now, there are people high up talking about that ER holding area. There's going to be more to come on this. That area might get blown up and rethought. So just know that there's going to be more to come on that. but we know that is a sore spot for a lot of folks. So there are a lot of staff early in their career in our hospital. And I see that as a strength because a lot of the newer staff members, they're the ones closer to the knowledge, but there's also knowledge with experience as well, okay? I talked a little bit earlier on about making sure that staff has opportunity to grow in terms of continuing education, in terms of training, and that is something that we're going to be looking at. There's a lot of different service lines that are coming online right now, neurosurgery folks. We're seeing patients who are sicker, needing more balloon pumps, swans, swan gangs catheters, and people that have had that experience, we can get them more in a leadership role in terms of becoming super users. So how's that going to look? IVs, we have a really strong IV team, PIT team that comes by, but there's opportunities that were voiced in terms of making sure that all of our staff was knowledgeable in terms of starting IVs as well, and especially with ultrasound guidance. And then ongoing education for respiratory therapists, that was something that was voiced as well. So in order to help with those concerns and opportunities, what we have already started is monthly didactic sessions for nursing. So starting in January, I'm going to lead the first didactic session for our nurses. And every month, we're going to have different learning opportunities for them. There'll be a different theme for the month. So January, I think, is chest tubes. February is going to be CRRT, troubleshooting. March is going to be EVDs with neurosurgery. I already had some buy-in with neurosurgery, thoracic surgery, and our cardiology folks to help. Hands-on skill fairs is going to be something that you're going to see a little bit more often. Another thing that's going to be a little bit more relevant for folks in this room is that we are going to start our respiratory lunch and learns. This is our first one, kind of giving an overview, but we're going to be meeting like this every so often in terms of going over topics, right? So refractory hypoxia, or vent dysynchrony, or just reviewing the basics like asthma, COPD care, just reviewing the basics, just making sure that we're just continuing our learning opportunities from a respiratory standpoint, nursing standpoint, and if there's other departments that find the opportunities to do some talks or research or anything like that, definitely approach me. We can work something out. So I'm happy to do that. We already talked about these different service lines coming on with their fancy pants equipment that's going to come into the ICU, and establishing super users might be helpful. Somebody that you can go to and troubleshoot, ask questions to. Belinda, our critical care nursing director, is really rethinking these code blue meetings. We used to have these every so often where we review the code blues that happen in the hospital, but she's reimagining this to a little bit more of a learning opportunity where I'm going to start to review the code blues that happen, especially off the floor, and people that land up in the ICU, and just make sure that we did everything that we're supposed to be doing, and make sure that there's no areas of opportunity in terms of processes. If there is, we're going to talk that out, and if there's things that we can do to improve in terms of protocols and processes, we'll improve on that. But a little bit separate from that is something that is a little more near and dear to my heart: morbidity and mortality. I'm not sure if you guys have either heard about morbidity and mortality or been sat down at a conference where they've done an M&M, but this is something that we emphasize a lot in our training. It stemmed from surgeons going over difficult cases where there may have been a bad outcome, and it's really a learning opportunity. It's not a time to point fingers at folks and say, hey, you messed up, and this is what you did wrong, and you're stupid, and all that. It's a learning opportunity. You try to keep the patient and the providers or whoever was involved as anonymous as possible. Hey, this is the case, this is what happened, And this is our areas of opportunity. These are the areas of learning. This is where you zigged, where you could have zagged, that sort of thing, and you review the literature, you review the research, that sort of thing. And the reason why I'm bringing it up here is because this is going to start to happen within the next several months, probably like Q2, April, May, June-ish. But I want you guys to start thinking about these cases that you're involved in, and some of these cases where you feel like, you know, things went south and maybe there was some opportunities there, or there was a little bit of meat on those bones where we could have done something else and everything. I want you to bring those cases to me, okay? So it gets on my radar, and if it rises to level, we can talk about it at this conference and everybody can learn. Because at the end of the day, that's what we're here to do. We're here to get better, okay? Because if we keep on staying in the routine that we're in and we're not learning anything, we're just going to keep on making the same mistakes. Okay, so that's what this is about, the Code Blue meetings and the morbidity and mortality. Is a big one for me. Again, I harp on the fact that we need to do the best for our patients. We need to make sure that we're delivering exceptional patient care, timely care, efficient care, and keeping our patients safe. In that same breath, we need to make sure that our staff and everybody caring for the patient has everything they need, has everything to keep them supported, has everything to keep them safe. I think if you focus on that and we give you the tools that you guys need, we're able to complete our task and we're able to do our job efficiently, okay, and effectively. So I want to make it a emphasis to keep you guys safe. And at the top of the list, there was a lot of talk and discussion about the visitation policy. That's changing, okay? I can speak a little bit more about that, but there's been a lot of behind the scenes talks and everything. But what we talked about last week at the meeting was that there is a law in Georgia that was passed post-COVID or during COVID, where you had a lot of patients that were, they were alone, where we weren't letting family members in the room for safety reasons, right? And COVID and when it spread and everything. There was a law that passed as a result of that, where no patient is able to be left alone. Family members are allowed to be allowed into the room. And I don't know where it got lost in communication, but somehow that got translated in the past several months to let's let the floodgates open, right? That's not what the law says. That's not how it was supposed to be interpreted here, and we're fixing it, okay? So we're trying to find the right verbiage right now, the right way to communicate to families in terms of that, but just know that that is a work in progress, that is changing, and I know there's been a lot of challenges that has arose from that, and that's changing, okay? Because again, at the end of the day, we need to be able to care for our patients, and if there's 38 people in the room, it's hard to get to the patient and deliver effective care, okay? Of course, there's going to be sort of exceptions and everything, patients that are on comfort care and families, need to visit and everything. But, just the 38 people letting a room and just camping out and setting up shop and everything, that's not going to be a thing, okay? So that was one of the first things I looked at, all right? I didn't know where to put this in the presentation, but I felt pretty strongly about this too, so I stuck it here. Everybody in the ICU should have their rings off. If you come into a room, an ICU room, and you see a patient with the ring still on, please tell somebody, nursing staff, provider, and everything. People get swollen in the ICU, rings get stuck on, it becomes a big issue. Rings should be off. So if you see that, please escalate that so we can do that. Staff safety measures kind of goes along with the visitation policy, that sort of thing. Making sure that you guys have everything you need, especially during peak times in terms of resources, that sort of thing. So. I want to make sure that we are keeping in communication with our different departments. So we have folks from the ODB department that have had several patients in our ICUs, especially over the last couple of months. It seems like it comes in waves. But I want to make sure that, you know, their needs are met and making sure that we understand what types of interventions that their patients need. So we're going to be having more meetings, collaborative meetings with the OB department, ED, anesthesia, making sure that we're just staying in proper communication with them. Another thing that could help our cause is making sure that those 3 a.m. rounds at night are being done. Because if you think about it, it kind of starts there. If you guys are not aware that there is a 3 a.m. round with the APP that's on overnight, the charge nurse, respiratory therapist, and making sure that we're going around the unit, identifying people that are candidates for spontaneous awakening trials, spontaneous breathing trials, making sure that there's no active issues, making sure that people have diet orders and tube feed orders. All that happens during those 3 a.m. rounds. So ensuring that that's getting done is a critical part of what we're doing here. How many people in this room have seen this graph or this chart? Probably not. So this is our sepsis dashboard. This is pretty much our report card in terms of how we're doing delivering timely sepsis care to our patients. This involves everybody in this room. It's probably more aimed towards nursing more than anybody and the providers, but I just want to make this more for your awareness that overall our sepsis care here at Piedmont Fayette is pretty good, but obviously we have some areas of opportunity. This should be around 70% in terms of our 1 hour bundle initiation. Fluids, we always fall a little short of, but as you notice our mortality where the benchmark is 20%, we're at about 7% for the last several months. So this is about 3 months worth of data, so we're about 7 months. So overall, we do pretty well with sepsis care, but there's some areas of opportunity here. The reason why I'm bringing this to y'all's attention is because it takes a village, right? So if somebody has a red sepsis alert and things need to get done and you're not seeing them get done, I want everybody here to feel empowered to ask questions and raise, issues where, hey, this patient had a red sepsis alert. Do they need fluids? Like that sort of thing. Is the lab coming to get blood cultures? So you guys have the power to at least speak up, ask questions in terms of patients who are at risk for newer developing sepsis, and I want to make sure that we're all involved in that case. So I'm just kind of bringing this to y'all's awareness, but I'll kind of go over this. So this is a particular metric that I wanted to bring to y'all's attention. And this is a result of a RL that was filed. So the first takeaway from this is that we read your RLs that you place, and everybody does an excellent job at placing RLs. I have the distinct opportunity going through a whole bunch of those, so thank you for that. Keep them coming. But this is a direct result of an RL where there was actually a policy change about to happen because of it, okay? So keep that in mind. I can't take full credit for this. This RL and kind of some of the background stem from a patient that was ventilated for an extended period of time, and after, let's say, like 12 days, got extubated, and with most of our extubations, when we got extubated, the OG tube was removed, and this patient was very deconditioned, and the provider was very skittish, or providers were very skittish about placing an NG tube for ongoing nutrition and medications because we don't cause an aspiration issue and all that. So the patient went an additional 5 days without getting fed, right? Not good, right? So what can we do to improve on that? And so we started talking that out, or I brought that to my group and talked it out with some of the other service lines, especially dietitians, and we talked about how we can improve on that. And during our discussions, Dr. Panamalan went on this big old rant about other things that we can improve on, and so Dr. Panamalan should get a lot of credit for what this initiative is about. But basically, this is looking at our patients that are in danger of having a prolonged intubation, okay? Where you have, patients that are intubated for a long time. They don't get up a lot of times because they're just so sick, they're hemodynamically unstable, or they're super hypoxic. A lot of times we end up not being able to properly feed these people because they're on high pressure requirements, that sort of thing. A lot of times the providers get into the weeds and 4 or 5 days have gone by and we've had no family discussions or lack of even identifying who the correct power of attorney is. People who are intubated 4 or more days are at risk for delirium, we know that. And sometimes we miss the opportunity to have early trach talks. So just a lot of different issues come up with people who have prolonged intubations. So what we wanted to do was start to identify these people that have been intubated 4 or more days that are at risk for a prolonged intubation, to make sure that we are doing everything we need to do to help that patient along their trajectory, right? Whether it's talking about trachs, whether it's identifying people who need to have proper nutrition after extubation, whether it's making sure that we have proper family meetings with these patients, making sure that we're doing all these things. So our initiative here is at day 4 of intubation, these questions pop up and get asked during our interdisciplinary rounds. We need an outside person to really help push this issue, because if you leave it on the provider or maybe the bedside nurse, I feel like that's an opportunity for things to get swept between the rug and fall between the cracks, but maybe the charge nurse be in charge of that. But this is stuff that needs to be talked out a little bit more. But the idea there is here is that we are going to start verbalizing during our rounds, hey, is this patient going to be potentially a candidate for extubation within the next 48 to 72 hours? The answer is yes, cool, we keep it moving. If the answer is no, then we really need to start thinking about what we're doing in terms of potential trach and making sure that timing lines up, the people who do trachs are going to be on service, just stuff like that, making sure we're talking to the family. Speaking of family, making sure that we're having these trach conversations. And this is something that hasn't been put into this conversation, but I had a conversation with supportive medicine, and I was actually on a critical care committee meeting last week, and one of the recurrent themes, not only at Piedmont Fayette, but at all of our other hospitals, our brother and sister hospitals, is that we don't do as great of a job at identifying who the proper POA is. Okay, we'll talk to a family member for like 3 or 4 days and we'll give them updates and all that because they've identified themselves as the brother of the patient and all that. And it turns out after day 4 or 5, yeah, it's the patient's frat brother who they, go out and hang out with and all that, when the actual brother lives like down the street.
Oh my goodness.
So that stuff happens. So we need to formalize that process a little bit more. It's not just us in the ICU. This also involves maybe IMS at admission, but this process needs to be formalized a little bit more. But this is something that I think everybody in this room can be a part of, right? So as you're walking patients and all that, you're having that conversation, hey, who's your family, who's taking care of you? When you're introducing yourself, okay, you're such and such, okay. you're speaking for this patient, so you can all have these conversations. And if you find out new information that changes who the POA is, changes who we're talking about, please bring that to our attention. But what we're going to try to do is try to formalize a process to where that's identified like on a daily basis on rounds, making sure that everybody on the treatment team is on the same page in terms of who the POA is, who we need to be giving this critical information to, because that's a vital process in terms of caring for our patients. Feeding and nutrition. There was a lot of talk about these long-term patients in terms of how we should proceed if a patient after 10 days of intubation is about to get extubated, right? There was some thought about reflexively putting an NG tube in all patients that are on day 4 of intubation versus some other plan. What ultimately came of that talk, for right now, what we would try to do is be a little bit more mindful about patients that are getting extubated, making sure that if a patient is extubated after day 10, day 12, that we've had that conversation in terms of, hey, this patient may be a little deconditioned, might be a good idea to drop an NG tube prior to extubation. What we don't want to do is have an NG tube laying in for days and days and days, create a risk for sinusitis, that sort of thing. So, you know, we talked that out a little bit, but as of right now, we just want to make sure we have that conversation. But again, a formal process will be on the way for this as well. Post-extubation strength evaluation. It has been verbalized to me that a lot of times PTOT orders fall off. Patients are not getting the opportunity to work with you guys in a timely fashion. So we need to do a better job as providers, making sure that you guys have proper orders and we're on the same page in terms of making sure patients are getting up and evaluated early. You will find that I am one of the biggest proponents of getting somebody up out of the bed. I love the fact that we were walking people with tubes in their throats and all that good stuff, intubated, sedated patients. I love that. So anything that we can do from our end to make that happen for you guys in terms of physical therapy, occupational therapy, bring it on. Thank you. And again, family meetings, making sure that this is happening in a timely fashion. This is a initiative that is system-wide from our critical care collaborative. There is a formal way that we have discussed doing family meetings and making sure that all the people are involved. But again, one of my points of emphasis is making sure that we're identifying the right POA and having the correct conversations with the correct person. I mentioned a lot here. I ran my mouth here for the last, 30 minutes or so, but I talked a lot about all the items in this chart, except this first one. I didn't talk much about pain, but that's important too. Y'all should assess and manage pain. But spontaneous awakening trials, spontaneous breathing trials, sedation, analgesia, making sure that people are up early. So this list that you see here is all the stuff that I talked about, all the stuff that we can do better on, all the stuff that we can focus on, right? If we do this list, we are going to make ourselves better. We're going to make this ICU better. We're going to make our critical care services and the way that we deliver critical care better. But this list is the criteria that makes an ICU a center of excellence. Okay, so I took this exact diagram or exact chart from the Society of Critical Care Medicine. Okay, so you can see if we focus on the things that we're talking about, the focus on the things that we have concerns about, if we stick to the plan, we become a center of excellence. We become a highly functioning ICU, one of the best in the country. Okay, we have the people in place to do that. All right, I am totally confident. We have done amazing things. We have come a long way throughout these past 6 years that I've been here, and we have a super duper strong staff, and I believe we have all the tools in place, all the staff in place to make this happen, okay? I put this next chart up as a scorecard / report card for y'all to hold me accountable, okay? So a couple of things I talked about. I want to set some timelines, I want to set some deadlines. So again, y'all hold me accountable. So during the next 3 months, what I hope to at least get started, rolled out, is that day 4 review process that I just talked about. I want to get that up and running. I feel like that is something that we can get going in a timely fashion. The ICU communication algorithm, I think that's important to get going sooner rather than later to make sure that communication is flowing properly in our ICU. And I already talked about the fact that January is going to be our first education session. I can't wait to get started in terms of RT lunch and learns. Anybody should be invited to that, especially from the RT staff. But I'm going to, again, be available for that, and I will also volunteer my colleagues in order to help out with that as well. Second quarter, skills fair. I think it's important to have hands-on training, and if there is any opportunities for RTs or anybody else, PTOT and all that, if we have opportunities to have you guys involved in that as well, definitely more than welcome. SAT, SBT audits, we talked about that task force, improving that process, and really focusing on handoffs. And ongoing initiatives, critical care meetings, where all the people from the different departments, all the stakeholders will meet together on a quarterly basis. That schedule should be coming out pretty soon here. I want to make sure that after that meeting, everybody gets that information from that meeting, so we'll try to firm up that process. And meeting with all the different departments. Again, I want to emphasize the fact that anybody should be more than willing or available to come up to me with any questions, concerns that they have. So just to wrap it up here, again, I think that we are going to do great things. There is a lot of growth that has happened. We are going to grow even more here. We are definitely in a place to do amazing things here, but I just want to make sure that we keep a couple of things at our core as we go forth, in terms of making sure that we have good communication between us, within different departments, making sure that we are working safe, and making sure that we're working efficiently, making sure that we're working collaboratively, and making sure that everybody's holding up their end. I'm gonna stop here. Sorry I ran my mouth. But questions, comments, concerns at this point. Again, this was a big overview on what I want to do and where I'm seeing things going, but this is a fluid situation, okay? This is going to change over time, and definitely there's been more specifics talked about some of these initiatives outside of this meeting, but this is kind of like more of an overview more than anything. So questions?
So I just have a comment. So
please.
I was intubated after a procedure, so and I want to emphasize that it's important that the nurse and the respiratory therapist has a communication